Good morning and welcome to this session on terrorism management procedures and practical tips to optimize surgical outcome. We all know terrorism is one of the common problems we see in our day-to-day practice, and many surgeons still consider the humble terrorism to be unworthy of their talent and skill. And this dualization of terrorism surgery combined with poor surgical technique are responsible for poor or variable outcomes. So we have an excellent panel here, and every aspect of terrorism management, both surgical and medical management, is going to be covered in this 75 minutes course. Before that, we have a keynote address by Dr. Jeff Rose. Professor Jeffrey Rose, he is actually a member of Royal College of Physicians, and he has, during his ophthalmic training itself, he has received fellowship of the Royal College of Surgeons and Royal College of Ophthalmologists. He was appointed to the consultant staff at Moorfields Eye Hospital and has been director of the Adnexal service and is now an honorary consultant to the hospital. And he is a senior research fellow of Biomedical Research Center at the Institute of Ophthalmology, London, and is a past president of ESOPRS and a past president of BOPSS. So he is not able to come online, so he has recorded his presentation and sent it. So we are going to present his keynote address now. Yevi, can you just play his talk?
Thank you very much for the kind invitation to present a keynote lecture to the AIOS. I would like to talk about the giant Fornix syndrome, or 10 easy minutes to save an eye. So, the giant Fornix syndrome, how is it recognized? Well, in the 1990s, I saw a few very elderly patients who were referred with growth, chronic conjunctivitis, and lacrimal drainage obstruction, like this patient. Most had some degree of ptosis, often worse on the affected side. And here was a typical sort of patient, and when you looked, they had an absolutely filthy eye with a big mucocele. And at that time, I thought it was the toxic debris causing this problem with the cornea vascularization. It was just toxicity of the surface debris. Well, these patients would undergo successful and uncomplicated external DCR, and with complete elimination of the lacrimal sac mucocele, so there was no more debris to come back into the eye. After improving for a few days to a few weeks, the condition would actually then return to what it was before. And so what was going on here? I really couldn't make this out. Looking at the patients after DCR one day, I noted that one of the patients had a huge protein coagulum, like a fried egg, lodged deeply in the upper fornix, and you can just see the tip of the coagulum there. Very hard to illustrate because it's a very long way up, and lots of pus and debris around. The protein coagulum, when you removed it, always cultures Staphylococcus aureus, and the presence of this coagulum leads to a very severe, quite often hemorrhagic, conjunctival reaction. The bacteria and the toxins within the coagulum are pouring onto the ocular surface. So, how does this condition occur? Well, I present a hypothetical mechanism based on the work that I have done. First of all, these patients probably start with a severe chronic conjunctivitis due to the bacterial debris in the tear film. This causes ocular surface irritation and pseudomembrane formation due to the protein exudation into the tear lake. This then coagulates to form a bacterial-laden protein coagulum, which lodges itself in a very large upper fornix. That coagulum then keeps persistently re-inoculating the ocular surface with low-grade bacteria, it forms a petri dish, putting bacteria onto the front of the eye. And these bacteria in turn keep fueling the chronic conjunctivitis, so you get a positive feedback loop. A large lacrimal sac mucocele in these patients may well have been the initial early chronic infection in patients who are liable to form this positive feedback loop. The chronic inflammation and debris leads to an increase in conjunctival surface area due to papillary response and redundant conjunctival folds, and these in turn will give greater area for protein exudation and also more spaces in which you can develop a protein coagulum. As we get older, the upper fornix does get deeper with age due to disinsertion of the levator aponeurosis, so it's particularly a problem with elderly people who will get this huge upper fornix that can collect the coagulum. And the chronic severe ocular surface inflammation worsens the ptosis in these patients, and that in turn also deepens the upper fornix. So what are the characteristics of the giant fornix syndrome, which I described back about 20 years ago now? Well, I had 12 patients, of whom 10 were female. They're aged 77 to 93, so they're all in their 9th and 10th decade. And these patients typically had lots of episodes of severe conjunctivitis over anything from 1 to 4 years. It often passed unrecognized for long periods, and indeed I didn't recognize it in the early days. I thought it was all down to the lacrimal sac mucocele, and it was only when you had persistent problems after a successful DCR that I wondered what was going on. What is the importance of this condition? Well, it has major visual morbidity. 9 out of the 12 patients that were referred had severe corneal vascularization due to the extreme toxicity and the cytokines and the vasoactive agents that were secreted in this toxic tear And in 8 of those patients, the acuity was counting fingers or less when they were finally referred to me. The second area of importance is that there is major ocular morbidity associated, in that it is so toxic that you get corneal melting, and 5 of the 12 patients had spontaneous corneal perforation or decimetocele, as here you can see the decimetocele. So how do we treat the giant fornix syndrome? Well, in many patients in the UK, they can't treat themselves effectively at home. They're far too elderly, and so we may admit them for a day or 2. We then treat them with hourly potent steroids to quieten the inflammatory response, and 2-hourly anti-staphylococcal agent. We will also give them systemic ciprofloxacin for 5 days, because these highly inflamed surfaces settle much faster with a bit of systemic antibiotic. And in some cases, if there's a lot of coagulum formation, you can sweep the upper fornix with a methocaine, tetracaine soaked cotton bud 2 or 3 times daily to remove the coagulum. You only need to do this for a day or 2. Long term, these patients, you should tail down the topical treatment very, very slowly over weeks to months. They have had such severe inflammation that if you suddenly stop the topical treatment, you will get a recurrence of the disease. You may need to perform lacrimal drainage surgery if there is a mucocele, and it may be necessary to continue the once daily dosage for topical antibiotic steroid preparation, for example at night, long term, because these patients with their large fornix are liable to relapse at some stage. The alternative is to use once daily polyviridone iodine 5% eye drops. Again, they're used at night. It's a good time to use them. And some patients who have an abnormally large fornix and really don't settle, one can consider resecting some of the upper fornix conjunctiva. So in summary, when you see this sort of patient with a filthy eye, ptosis, elderly patient, they've already got an aponeurosis disinsertion, but it's markedly increased on the side where it's mucky, and huge ptosis, and an ocular surface that is looking extremely filthy. Think giant fornix syndrome, and you will save these patients ending up with visions down at count fingers and so on, and the severe complications like perforation. Thank you very much, everyone.
Thank you, Dr. Professor Jeff Rose, for this wonderful keynote. And let us move on to our session, pterygium management. So the first talk is on conjunctival autografting, my choice in pterygium surgery, primary pterygium, by Dr. Ilan Kumaran Paspati. Dr. Ilan is director of Navashakti Nethralaya. He is MD from All India Institute of Medical Sciences and is a former consultant at Netradhama Hospital, Bangalore. And he is presently the chairman of Scientific Committee of Karnataka Ophthalmic Society. He is an excellent phaco-refractive and corneal surgeon. Over to you, Dr. Ilan.
Thanks a lot, Dr. Sirish. Am I audible?
Yeah, yes.
Thank you.
Sure.
At the outset, I'd like to thank Dr. Sirisha Kumar for giving me this opportunity, and the Scientific Committee Chairman, Dr. Partha Biswas sir, for giving me this opportunity. There's no other tissue in the body which has undergone all this: incised, removed, split, excised, dissected, cauterized, galvanized, heated, coagulated, irradiated, rotated, depositioned, inverted, transplanted, and grafted. Way back in 1953, Dr. Rosenthal had commented about it. And what is so special about this tissue? Despite all these, it's notorious for its recurrence. We are going to talk about how to reduce the recurrences, and one of the techniques which is used, most common technique, that is conjunctival autografting. So in any case of pterygium, I would like to do conjunctival autografting. Let's also remember Shushruta, our own. What is important here, way back in 100 BC, he had described the pterygium procedure. And please look at these two particular sentences, two particular points. Root of the pterygium should be pushed back from the black outline, and it has to be removed in toto, even if necessary, with a scarifying agent. But then we all know what the scarifying agent is to do. What are the options we have as of now for treating pterygium? Simple, old bare sclera. We used to do this long back. Or transposition of the head, shifting the head to a different direction so that it grows elsewhere. Conjunctival autografts or rotation grafts, amniotic membrane grafting, or limbal conjunctival autografts, or use of any adjuvant, those scarifying agents which he was talking about. These are not scarifying, but reducing the, or use of lasers. Of these, the three common procedures that are used nowadays are this, something to do with grafting. Either it could be conjunctival, amniotic, or LCAT, what you used to call it. As regards the recurrence rate, that's the biggest problem. Now, if you look at the recurrence rate, I've taken just one article, different article gives different recurrence rate. This was a meta-analysis actually. But then, if you look at the lowest recurrence rate, it is with this conjunctival autograft with fibrin glue. Of course, there are a few procedures perfect and others with an even lesser recurrence rates, but not many of us are doing those procedures. Among the common procedures performed, it is the conjunctival autograft with fibrin glue that gave the best possible results in terms of recurrence. And of course, worst, obviously we know, either bare sclera or the primary closure that we used to do. Now, how does this help in preventing a recurrence? Limbal autografts have been successful by two methods. One, It corrects the limbal dysfunction. In case of limbal insufficiency, LCAT, limbal autoconjunctival transplantation, is much better. But more importantly, it acts as a barrier against any conjunctival infection of the cornea. It's a physical barrier. Of course, it can supply the stem cells if those are used. In case of any suspicion that it's going to, already there is a stem cell deficiency and it's going to worsen, then the same autograft can be obtained. The graft can be obtained from the other eye. Two methods. One, either we place the graft, slide it and place the graft, or a rotational grafting can be done. Rotational grafting is a cumbersome procedure, can be done for smaller lesions, not for larger lesions. The preferred technique is a conjunctival graft, where it is harvested from the superior part of the conjunctiva, preferably, and then slided over the cornea and then fixated. Now, I'll be showing three different methods of what I should do and simultaneously talk about it. This was a video recorded, I think, way back in 2003 or 4. It's a long video. I'll be fast forwarding this. First of all, measure the pterygium. Make sure we mark on the superior part of the conjunctiva. Use a mark. And then dissect the pterygium. Whatever, there are various methods for this. Dissect the pterygium, make sure the fibrotic tissue is removed completely, the subconjunctival tissue. Meanwhile, trying to retain as much of conjunctiva as possible. Remember, pterygium, it's not the fault of the conjunctiva, but it's a subconjunctival elastotic degeneration. So that subconjunctival tissue, we have to concentrate, remove it, at the same time taking care not to damage the medial rectus. Particularly in recurrent pterygium cases. Primary pterygium, it's easy, but recurrent pterygium cases, we have to be more careful. And then in this case, those days we used to use mitomycin C also. I've used the mitomycin C, then infiltrate xylocaine in that marked area. The same size is marked here, but however, when we cut, you will be noticing that it will be slightly larger than the marked area that we take. And with a conjunctival scissors, the flap is created, making sure that it's slightly larger than the marked area, as well as the thinnest possible flap without any conjunctival buttonholing is to be obtained. So the tenons, if at all, if it is there, has to be removed so that there is better adhesion here. So I'll try to fast forward. Now, how do we take this? Remember, this limbal orientation has to be maintained here. So after separating the graft, it's better to slide it, or at least some people use a linear mark so that it can be. In this case, I've got hold of with 2 forceps and then shifted it so that the limbus part remains on the limbal side. And this is one of the oldest cases. Fibrin glue was not available. We had not designed any new techniques. So I'll be using 80 Vicryl to suture this. Point to be noted, I'll just fast forward to the end. Point to be noted is that perfect opposition has to be obtained. Any space that is left out, there's a chance of recurrence. The donor area is also sutured. Now, with the advent of new techniques, we got this. Somewhere down the line, we got glues, biological. Mark the conjunctiva. Make sure that you mark the area where there's a difference from the normal conjunctiva to the abnormal. That much is enough. And then the subconjunctival tissue is removed. Sorry, I'll fast forward it. Making sure that there is a polishing done. And then the graft, in this case, was slided. The glue appears in 2 different containers, but one on each side, fibrin, and the other one on each side. Again, make sure that there is very good opposition on all sides, so that in the end, make sure that this opposition is done. The glue is put on 2 different surfaces so that there is enough time for opposition. Lack of time. This is the glue, very costly. Nowadays, it's not available. So we have the Indian variants, but the Indian variants are not working so well. One of the alternatives that came up a few years back was to use patients' own autologous serum. How do we obtain this? I'll skip the pterygium removal part. The conjunctival graft is obtained. slided onto it. But what is more important, before this graft was obtained, this area was cauterized so that there's no excess blood. And then just before placing the graft, fresh bleeding is induced among 1 or 2. We need fresh blood, remember that. And this works as well as the fibrin glue. My last slide. Now, which is better, suture, glue, or autologous blood? Now, that's what is answered here. If you carefully read it, fibrin glue remains the most effective method. Why is this? Because it's easier to do, holds on longer. But then when we compare it, if easier alternative would be autologous blood, it's an effective alternative, easily available, economical. But then what is the problem here? If fresh blood is not used, we will lose that graft the next day. Use of sutures, old technique, more surgical time, more complications. So I would prefer to do my autologous, autograft with autologous serum nowadays. And if you carefully look at this, these are the techniques that are available. Forget about the first 2 or 3. All the others have a conjectable autograph. For recurrent pterygia, we use the adjuncts. Thank you once again for providing me this opportunity.
Thank you, Ilan. It was a nice presentation. I have 2 questions for you. So we know conjunctival autografting is the gold standard in the management of primary pterygium. What if the superior conjunctiva is not available? What is your choice? Second one, nowadays many of the surgeons, they routinely do inferior conjunctival autografting. What is your opinion on that?
A very, very good question. The superior conjunctiva is always preferred. Number 1, for the simple thing that it can be obtained. Number 2, also, we are sitting on the superior end or the temporal end, so it's easier to obtain that. However, in cases of fibrosis, previous blood, or glaucoma patients or family history of glaucoma, this superior part has to be retained. So some of them prefer to take it from the inferior part. Yes, the same precautions can be followed. However, the wound in superior part, sometimes even if we leave the wound, if it's a small one, if we leave the wound, it heals on its own. But inferior part, I would prefer to always place a suture or glue.
Thank you, Dr. Ilan. It was a nice presentation. Let us move on to the next talk by Dr. Sean. The talk is on cataract surgery with pterygium surgery, simultaneous or sequential. So, Dr. Sean is a dynamic, charming young ophthalmologist, cornea refractive surgeon. He did his fellowship from Aravind Eye Hospital, cornea refractive surgery. And he was with us at the Eye Foundation Bangalore as the medical superintendent for almost 7 years. And now he has moved to his native Goa. He is working with ASG Eye Hospital now. And so a very good phaco refractive surgeon. It's over to you, Sean.
Thank you very much, Dr. Shirish, for inviting me. And I think every year this is a very interesting IC which covers pterygium very comprehensively. So what I'll be talking on is on decision making when you have a cataract with a pterygium on simultaneous versus sequential surgery. So I think my video has been stopped by the host.
Oh, okay.
So as we see the prevalence of pterygium, it's a range from 6.3 to 16% with a higher prevalence in the rural places. And this incidence increases with age and geographic latitude. Similarly, cataract is also a common age-related condition seen in these age groups, and exposure to sunlight and ultraviolet B rays is common to both the diseases. So when we take a decision on whether to do it sequential or simultaneously, factors prefer more for sequential surgery. These include the size and the location of pterygium, if it is more than 3 millimeters in size, a pterygium which is encroaching the visual axis, or in cases of double-headed pterygium where you have nasal and temporal tissue, distortion of the Myers on keratometry if you're not able to get a good corneal reading, or if you have a topography, you can get a topographic scan done, and if you see the anterior surface having an irregular astigmatism. Other factors include a significant cylinder warranting a toric IOL. You would not combine it in a simultaneous surgery. Or in some cases where the patient is very keen on a presbyopic correcting IOL, this may sometimes be a two-step procedure where you remove the pterygium first, regularize the surface with a surface ablation, and then go for a multifocal toric lens. The depth of involvement is important, and in cases of recurrent pterygia where you're going to use mitomycin C, better to go for a sequential surgery, and patients having recurrent ocular surface issues. The advantages in sequential surgery is you can address each problem individually with at least a 6-week interval in between. This allows the corneal wound healing to be complete, and your post-operative steroid regimen and others, which you normally give after cataract surgery, would not interfere with the wound healing. You also get a good astigmatic stability, especially if you're considering a toric IOL where you have to estimate the axis of the cylinder and the magnitude, and you get a healthy ocular surface. 6 weeks post the pterygium removal, you go in for the cataract surgery. Prediction of IOL power is also important, and we know that the pterygium induces a flattening, and this causes a with the rule astigmatism. So if you want an accurate prediction of the IOL power and you're going for the premium lenses, it's better to go for a sequential surgery. And this can assure a patient with a good refractive outcome. So in this case, we can clearly see that the nasal pterygium is encroaching onto the visual axis. It's quite a thick, fleshy pterygium, and is correspondingly also affecting the topography with a flattening in that axis and a steepening vertically. This is a relatively thin pterygium, but it's encroaching much centrally into the visual axis and thereby causing a distortion of the Myers. And in both these cases, it is inevitable that you would go for a pterygium surgery first and then follow it later by the cataract surgery. Predictability of lens power, there are several calculations available, and various authors have been even tried to predict what change can be anticipated post-pterygium surgery, but however, you cannot be too accurate with this. The greater the pterygium or the larger the pterygium, especially more than 3 millimeters in size, there will be a greater change in the mean keratometry, and more the change in mean keratometry, your prediction errors are also likely to be higher. In this article, they had 60 cases studied, and although they said that simultaneous surgery was safe and effective, the accuracy was moderately predictable, and this occurs because of the myopic shift which occurs post-operatively, resulting from the steepening of the cornea after removal of the pterygium. Here, 48% of patients were within 0.5 diopters plus or minus, and 82% were within plus or minus 1 diopter post-surgery. Sequential surgery is considered, especially when there are practical constraints, especially in rural areas, in camp surgeries, in daily wage earners, because of loss of income due to hospitalization and delayed recovery. The indications would include a relatively smaller pterygium, presence of limbal delin, tear film disturbances. You're having a relatively clear visual axis, so you get a good keratometric reading. A superficial pterygium, patient is opting only for a monofocal intraocular lens, and you're having a good follow-up in the immediate post-operative period. This is a case in which you had a small peripheral pterygium not interfering much with the visual axis, and you can go for a simultaneous surgery combining both the pterygium and the cataract removal. So I'll just share a small video. This is thanks to Dr. Shirish. And here again, when you're going for a simultaneous surgery, better to avoid small incision surgery. Better to go for a phacoemulsification. Capsular staining does help in achieving a good rhexis, especially if the pterygium is obstructing the view. Then you go ahead with the phacoemulsification and placement of intraocular lens. Here, the one point I would defer is stripping off the pterygium for the corneal head. I would prefer to do prior to starting the cataract surgery. And after taking a good superior conjunctival autograft, Dr. Ilan has emphasized on a very clear dissection and followed by placement of the autograft onto the bare sclera using fibrin glue. Avoid a side port in the area of the epithelial defect, and in several cases we've seen a side port in the area of the epithelial defect where the pterygium is removed. That results in irregular healing and possibility of secondary infection. We've seen cases of secondary fungal infection of the cornea because post-cataract surgery you're going to have the patient on topical steroids, and this will promote bacterial and fungal infections in the eye. Avoid using MMC, and hence recurrent pterygium should not be done in a simultaneous surgery. Post-operative guidelines in these cases would be patch the eye, a good antibiotic cover post-operatively, use steroids in moderation, completely avoid non-steroidal anti-inflammatory drugs, especially in the first week post-operatively. Lubricants would be used as necessary to facilitate corneal wound healing, and follow up till the epithelial defect has healed. Thank you very much.
Thank you, Dr. Sean. It was a nice presentation. I have one question for you. So we can combine phaco with the pterygium, but can we combine the manual SICS with the pterygium? Because if you are doing a manual surgery, you will be dissecting the conjunctiva. How do you preserve the conjunctiva for grafting?
True. No, I would personally not prefer to combine a manual SICS, although we know we can make very small incisions. Because if you're taking the autograft, then you cannot take the superior autograft here because you won't be able to cover the surgical wound. And inferior autografts, although we've taken in several cases where it's really indicated, we know that a surgeon is not generally used to it, and you end up taking a lot of Tenon's tissue simultaneously. So I think if you have a phaco machine, you will definitely go for a smaller incision, better wound healing, and then take a superior autograft to cover up the pterygium barrier.
Maybe I think we can carefully dissect conjunctival tissue from tenons. So you can take a thin graft and cover the wound with the tenons. It is possible in a manual SICS. Any other opinions from other panelists? Dr. Namrata, Dr. JK?
We do manual SICS quite often with the pterygium, because most of the times they come with a very brown catheter wherever we feel is necessary. I don't see what is the big point, what Dr. Sian is. Each person, each surgeon maybe. As you said, we can do it. But I have a question for Dr. Sian. What K readings, how do you hear in pterygium? For example, most of the times you do have some astigmatism, So is there any cutoff point you take where you do simultaneous surgery, or you defer step-by-step surgery, or you look at the topography maps, or any cutoff point? And if it's a simple case, don't worry about the very demanding patient, multifocal or something like that. Just you are going for normal patient with the pterygium excision. So if you have 3 or 2 diopters, 4 diopters of astigmatism showing, how do you come to your conclusion? Whether you use the same K readings, or you have any other method, or how do you adjust the IOL powers? Do you have any suggestions for that?
I do not do this personally, sir, but yes, I think 2 things that we can look at is leaving a patient with a monofocal IOL and a residual cylinder, which is 2.5 diopters, would definitely be unsatisfactory. So I think I could keep an arbitrary cutoff of a 2.5 cylinder, where I would generally advise the patient to go for the sequential surgery. And as far as the second question was,
any adjustment? How do you, for example,
the IOL power, right? So you would expect a little bit of steepening of the cornea post-surgery. This is because of the coupling effect. So in these cases, you can consider slightly undercorrecting by 0.5 diopters if you're combining the surgery.
Sometimes what we do is we take a clue from the other eye, K reading. If other eye excellent is same and K, so we presume both are same and borrow K reading from that, because pterygium, as you know, it flattens the horizontal axis. Once we remove it, the total corneal power.
And I think Dr. Shirish also has a very interesting article where he preserved the conjunctiva of the pterygium tissue itself and used it for autografting. That can be done when you're combining with an SICS if there's no other option.
Dr. JK, we have done a study, actually it's published in International Journal of Ophthalmology, where we have taken 2 diopters as a cutoff point, and less than 2 diopters we have done a combined surgery, and more than that we've done a sequential surgery, and we undercorrect them by 0.5 diopters because there is a chance of steepening after the surgery. So we undercorrect them by 0.5 diopters for any spherical error, myopic error which is going to happen after the surgery.
That's a good idea. That's a good information for especially for a lot of people.
So, but of course we avoid toric lenses in these cases when we are combining it with pterygium, or we avoid premium multifocal lenses. So the next talk, Dr. Namrata, there's a slight change. Dr. Namrata Sharma is going to talk on her topic because she has sessions to other sessions also. So, like Dr. Namrata, we all know she is the Honorary General Secretary of All India Institute, All India Ophthalmic Society, and she is a professor cornea refractive surgery at All India Institute of Medical Sciences. She is academician. She is a fellow from Moorfields, and she has got more than 400 publications to her credit and more than 100 textbook chapters. And she has more than 11 textbooks in her name. So very dynamic young lady and excellent cornea refractive surgeon. So it's over to you, Dr.
Thank you. Thank you, Dr. Sirish, and thank you for making me a part of this. I know you've been doing this course for so many years and it is so popular. I'm going to be talking to you about complications of pterygium surgery, and sometimes you do have a good outcome like this after pterygium excision with the conjunctival autograft. This is post-op day 3 and this is post-op day 8. But it may not be as good as this in all the cases, and there may be problems. And this is yet another case. You can see a small del in there. So the problems could be intraoperative or could be post-operative. So intraoperatively could have done a deep dissection, excessive cautery damage to the extraocular muscles, perforation, bleeding, canalicular damage, reversal, loss or tear of the conjunctival autograft. And post-operatively, there could be recurrence, graft-related complications, donor site complications, and generalized ocular complications. So I think I would like to classify them into vision-threatening complications and the non-vision threatening complications. And this is a wonderful paper on pterygium, came way back almost a few years ago on options and adjuvants in the surgery for pterygium. So the vision-threatening complications are scleral thinning or ulceration, delayed conjunctival epithelialization, iritis, and symblepharon. And whenever there is any scleral thinning or ulceration, it has been shown that it was associated with intraop and post-op use of mitomycin C, greater rates of scleral thinning and ulceration with increasing intraoperative or post-operative mitomycin C concentration and with longer duration of application have been seen. Apart from this, there can be delayed conjunctival epithelialization, and you call it delayed when it doesn't occur until 2 to 3 weeks post-operatively. And it cannot be determined from the available results which are there whether intraoperative or post-operative mitomycin C use is actually associated with greater rates of delayed epithelialization. Then symblepharon can occur in 2 to 10% cases more with the Bayer sclera technique, and as compared to the other techniques, and less so with the amniotic membrane transplantation. Corneal delin is something which is very common and occurs with all forms of surgery, although the chances would be less with the conjunctival autograft, 1 to 6%, Bayer sclera is 3 to 5%. And again, the intraoperative use of mitomycin C as well as the post-op use of mitomycin C has also caused the formation of corneal delin, and very logically, it has been never reported after amniotic membrane transplantation. Now, non-vision threatening complications could be post-op astigmatism, which maybe they're more with the Bayer sclera technique, which I think people hardly use now. Pyogenic granuloma can occur with extensive pterygia, mainly because you've handled the conjunctiva too much, and also been associated with intraoperative and post-operative use of mitomycin C. It occurs more frequently in those cases which have used higher concentration of mitomycin C, and of course there can be recurrent pterygium, and I know there is a whole talk on this, so I will not be dealing with it. Graft-related problems could be as shown, so there could be graft contraction, there can be graft edema like this, dehiscence, necrosis, graft buttonhole and tear, and graft hyperemia, and this is a reverse graft with a graft necrosis which was inadvertently transplanted. Again, this is just to show that there can be inclusion cysts, the delin here, the graft edema again, which can be seen, and you stay with the fluorescein dye to see the edges, because at times the edges may not be visible. Then there can be graft retraction as well. This is a pyogenic granuloma which is there, and the immediate treatment would be that you would give topical steroids, and of course it doesn't get treated by this, then subsequently amniotic membrane transplantation can be done. I will not deal with the recurrent pterygium, only this to show that how a recurrent pterygium can lead to a lot of corneal haze which is there, so much so that you may require a lamellar keratoplasty after dealing with the recurrent, after removing the pterygia as well as the pseudopterygia, and especially because it is impinging on the visual axis, and so you may have to put a graft there. and subsequently may have to even go for a lamellar keratoplasty at a later date. Now, this is a case of pseudoteresia. So, autoconj with glue was done here. Notice that there's foreshortening of the fornix on that side. Again, very careful dissection is required. And exuberant pseudoteresia such as this, which is also recurrent, can lead to recurrence again. And so, again, one has to be careful. Important thing is that you have to dissect it clearly away from the visual axis, and alternatively people have also done limbal stem cell transplantation in such cases, but it is best done sequentially, and it is important that you pull these fibrotic edges and then excise, because then the whole thing recedes back. Now this is just fashioning of the graft, which is being done from the other side, a conjunctival graft, and this is then placed with the help of the glue, just as you would place in any teresia case, followed by a bandage contact lens application after the amniotic membrane that has been put. And this is mainly been put because of the shortening on the medial side. Now, apart from this, I think I will skip this because this is recurrent. Now, this was an interesting case because this we actually planned a DALC with the amniotic membrane transplantation. But when we started to do this, we realized that this was a full thickness perforation which had occurred following teresia surgery, and 17 teresia surgery had been done. Patient came from Nepal in this eye itself, both for the medial and the lateral teresia. So, which may have got perforated, and finally it was realized that there was a perforation which is present at both the sides. So we had to finally do a full thickness penetrating keratoplasty. And topical mitomycin C does have its side effects, which are listed here, and I've also talked about it. I would again show you this case, which again was a post-teresia complication with the perforation. And again, in this case, also the fibrotic tissue was released, and dissection was done onto the cornea, which was lamellar. And this is a donor cornea which is taken and which is D-shaped to match the complementary bed, and again sutured with 10-0 monofilament nylon sutures. You can alternatively glue it also on to get a surface-to-surface apposition, and then suture it with 10-0 monofilament nylon sutures. Now this is just to show the post-op picture and pre-op and the post-op picture of the same. Now, this is what we've described, the scleroplasty, tuck-in scleroplasty, again, melt which occurred after pterygium surgery. So in this, the edges of the melt are freshened, and then a small peripheral ledge is made all around this area with the help of the crescent blade or the lamellar dissector. I would advise people not to use crescent because sometimes crescent creates its own plane rather than following the plane which is already there. And then this scleral tissue is taken. Of course, the central part has been used for a central penetrating keratoplasty, and this is then placed here. Edges of this can again be trimmed so that it doesn't become like a pillow, and the edges completely snugly fit the ledge which had been created all around. And then surface-to-surface apposition is caused with the help of the fibrin glue. And then you can also tuck in this scleroplasty or tuck in this scleral graft inside. Notice that I have not used any sutures, and then this is also then glued, followed by a bandage contact lens application. This was the pre-op picture, and this is how it looks post-op, and this is in the late post-op period. So this is a tuck-in scleroplasty, and we are publishing the series of this very soon. Then this is the last complication that can occur, surgically induced necrotizing scleritis after pterygium surgery. And suffice it to say that this has to be managed by steroids as well as immunosuppression. And one has to do resection of the necrotic tissue with the amniotic membrane transplantation or a corneoscleral patch graft in very severe cases. So to conclude, pterygium surgery should be done meticulously and not left to the juniors to do it, because it can lead to devastating sight-threatening as well as non-sight-threatening complications, and appropriate preventive measures have to be taken. So thank you very much for your kind attention.
Thanks, Dr. Namrata. It was a wonderful presentation, and I have covered almost all the aspects of complications of pterygium surgery. And one question to you, it's like, in your experience, what is the commonest cause of recurrence? And when do you expect this complication?
So I would expect recurrence in a case which is young, in a case which has got fleshy, kind of angry-looking pterygia, and uh, I think in these kind of cases, and also it would also depend perhaps on the occupation of the patient, because if the patient is, say, agricultural worker, you do a pterygium surgery, and then it is the propensity to have recurrence of pterygium would be much more in those cases.
No, like, have you noticed loss of graft in these cases, or is it because of the inflammation this recurrence has happened?
Because of inflammation, it could be there, but having said this, I don't know, but many as postgraduates, I think at that time nobody used to do conjunctival grafts. People did only bare sclera, and it was just Ellen would remember, it was just a 10-minute or 15-minute procedure, and the most junior resident was asked to be pterygium surgery. And I don't know how many actually recurred. We have no data of that at all. But I think bare sclera is something which is being done, and we do get cases which have been referred, done bare sclera, and if you do that, then the propensity of pterygium recurrence would be much more.
One more, you have shown that inverted graft. What you do if you see an inverted graft on day 2, day 3, you go ahead and reposition it, or
So on day 2 and day 3, you can perhaps go and reposition it back. But I've just done it in a couple of cases which did well, but I wouldn't have a very large series of those inverted grafts which have been done. I mean, I don't, only 2 of them that I can remember. Very conveniently, I can say done by my junior residents, but
okay.
were there.
Thanks a lot, Dr. Namrata. It's nice of you. Thank you. Thanks a lot. So next we will move on to the next topic. Is surgical techniques for recurrent pterygium. What is best by Dr. Shreyas. Shreyas is a young, dynamic, excellent corneal refractive surgeon from the Eye Foundation. He is vice chairman of Eye Foundation group of hospitals. And he is MS from Aravind Eye Hospital, and he did his fellowship in corneal refractive surgery from LVP Hyderabad. Over to you, Shreyas.
Thank you so much, SK sir, for having invited me in this session. Am I audible?
Yes, yes, Shreyas.
Okay, wonderful. So after the wonderful array of pictures and videos which Dr. Namrata Sharma showed, I'll deal with the specific aspect of complication of recurrent pterygium. So before we go into management of recurrent pterygium itself, what is special about recurrent pterygium? Why do we talk about it so much? More than the primary pterygium itself, which usually is an innocuous condition, just slightly cosmetically bothersome, maybe very rarely visually debilitating. It is a condition where the recurrence is actually worse than the primary problem, which has a more aggressive clinical course. It is more difficult to treat and is best avoided. It can invade the underlying fibrovascular planes, involve the recti, and can cause restrictive strabismus as well. So it's essentially a pterygium itself, as I will describe in the subsequent slide also, is a primary elastotic degeneration, whereas a recurrent pterygium is a completely different and distinct entity. And possibly the very word recurrent itself is a misnomer, because it's not really a recurrence of the pterygium in most cases. Very, very rarely you can have a UV-mediated recurrent pterygium happening over many, many years. But the most common recurrent pterygium is just a fibrovascular tissue, a pannus, which is kind of growing over the cornea, over the limbus. Along with it, it could be accompanied by some degree of limbal stem cell deficiency also. So the recurrence itself is not UV mediated. It is a fibroblastic proliferation. It's essentially a response to the surgical trauma that has been done, and is kind of akin to the histopathologically to that of a keloid tendency, with a kind of fibrotic tissue present in a recurrent pterygium. As already discussed by previous speakers, bare sclera has the highest recurrence rate. The rates vary widely depending on which article you're quoting. But suffice to say, conjunctival autograft and perfect technique appear to be the best. Perfect technique, however, has not caught on widely because it's kind of a very extensive surgery for a very, very small problem. And therefore, even though recurrence rates are less, it's not really caught on. Conjunctival autograft works extremely well. Comparing conjunctival autograft with amniotic membrane for especially large pterygia or double pterygia, where some may be using amniotic membranes, it is best avoided, as can be seen, because while amniotic membrane is better than not doing anything at all, is better than bare sclera, still compared to a conjunctival autograft, the risk of recurrence both after primary surgery as well as recurrent surgery is much, much higher. So the causes of recurrence, I mean, I think Dr. Ilan Kumaran has also alluded to this. Any insufficient graft size, thick grafts, a lot of tenon, any tissue retraction, as you can see in this picture, can all lead to recurrence. As Dr. Namrata Sharma also showed, graft inversion is another reason where, if not identified early, can lead to necrosis of graft and can predispose to recurrence. And occasionally you can have these small innocuous peripheral recurrences, which very often the patient themselves may not notice, but we see this on the slit lamp, is essentially because of inadequate peripheral excision of the conjunctival tissue of the primary pterygium, and that leads to a focal small recurrence. Usually can be left as it is, and no major intervention is required. Recurrent inflammation has been spoken about, and that's a major problem. And if there is a inflammation either because of excessive surgical manipulation or a young patient in an inflamed pterygia, all this can cause. So these are all essential factors to a conjunctival autograft. I will go on to the management itself. So CAG continues to be the best. You can combine it with a limbal autograft, or you could do a mini slet. The advantage of a mini slet over a limbal autograft is you can take a smaller amount of limbal tissue. Along with that, if there is excess area which is uncovered, which you have not covered with a conjunctival autograft, you could combine it with an AMT, though I would not suggest AMT as a primary procedure. So it's just one video which I'll show of a recurrent pterygia which had already been operated twice earlier in another center, and the patient came back with a third recurrence. So one thing with regard to dissecting a recurrent pterygia, how it differs from the primary pterygia, is that getting a plane can be a little more difficult. The normal plane, which is very, very easy to get in a primary pterygia, because of the extensive fibrovascular proliferation, the normal plane is lost. So you may have to be a little more meticulous in your dissection. You can encounter more bleeding. Adequate cautery is necessary. And then while peeling off the cornea, now peeling a primary pterygia will come off in one go, whereas a recurrent pterygia has a little more addition because it's a fibrovascular tissue, and it is kind of akin to dissecting a pannus following a chemical injury. So you may have slightly different planes, and you will have to meticulously dissect it out and ensure you leave behind a very smooth and even bed. You can take conjunctival tissue from the same eye or the other eye, especially if it has been operated 2 or 3 times before. The conjunctiva in the same eye might be very, very fibrotic superiorly, and you may not be able to harvest it very well. And it's important that we get a very generous, large graft to cover the entire area to prevent subsequent recurrence. Here I'm just combining it with a small mini slit, as this recurrent pterygia had involved almost 5.5–6 clock hours of the limbus. So I'm just taking a small amount of limbal tissue also, about half a clock hour of limbal tissue. And I will close the primary area of defect. And then I will place the large conjunctival autograft. And my preferred technique in these cases where I'm doing a large AMG or a conjunctival autograft is, instead of applying the glue primarily, I prefer to place the tissue, fold it in half, apply the glue. This way you don't have much excess glue and the tissue doesn't float over it, and it is actually well opposed and well adherent. And then subsequently you can place your slit pieces on top of it, and then glue it together and place a bandage contact lens, and you can provide excellent outcomes with just minimal scarring because of the primary surgery. Adjuvants are available for recurrent pterygia as well as primary pterygia, more useful in recurrent pterygia. I'll quickly run through them. Mitomycin C has been around forever, and it has been used intraoperatively and postoperatively, though intraoperatively is more common. It does reduce recurrence rates in both primary and recurrent pterygia, but complications with mitomycin C are well known, and you can have scleral melts, delayed epithelialization, and the subsequent problems of delayed epithelialization. 5FU, both topically and subconjunctivally with varying doses, has been used. Reduction in recurrence is controversial. It's not been found to be very effective. Side effects are lesser than mitomycin C. It is, however, epitheliotoxic. Bevacizumab has also been used because of the VEGF overexpression in recurrent pterygia. It is well tolerated, minimal side effects, but as we know, it requires multiple injections. There is a cost to it and recurrence after stopping the injection. So in conclusion, a meticulous dissection is necessary. You need a large donor graft size, which is properly fixated with either glue or sutures, and judicious use of adjuvants, though adjuvants are not really necessary if a good dissection and good graft has been adequately fixated. And prevention is definitely better than cure in this case. Thank you so much for your kind attention.
Thank you, Shreyas. Thank you, Shreyas. Yeah, I have one question for you. Like, if the superior conjunctiva is scarred or it's not available due to previous surgeries, so can you go ahead and do a slit with only amniotic membrane?
So,
and is there any study on this, and what is the result?
My preference would be to do only conjunctival autograft or conjunctival autograft with slit. I think the slit is optional. I've just done it in this case and I'm just showing it as an option. But conjunctival autograft, I think, is a must, because amniotic membrane does not stay for as long as we require for the entire epithelialization to happen. And a fresh AMG, if it sloughs off after 10 days or 2 weeks, it may not have been there for a sufficient period of time for entire reepithelialization to have occurred. And this can also predispose to a recurrence. And multiple studies have shown that AMT is much poorer than conjunctival autograft for primary surgery. The slit part, I would say, is more to have, it also tends over a period of time to reduce the amount of scarring that can be there over the corneal area. And that we've seen in both chemical injury as well as in these cases. And that would be possibly the better use of slit.
Just an idea, because there's amniotic membrane can stay for 2 weeks, 10 days, or 15 days. And this slit pieces can take care of limbal barrier function. Maybe like if the conjunctiva is not available, we can try this combination.
Could be, sir. Could be, sir. I mean, the amount of limbal stem cell deficiency which is there in recurrent pterygia itself is a little questionable, sir. The limbus itself may not be deficient. It is a more a fibrovascular tissue which has grown over during the healing period. So I don't know how much extent of LSCD is actually contributing to the recurrence of the pterygia.
Okay.
Thank you.
Thank you, Shreyas. It was a nice presentation. There's again a slight change in the talk. Dr. JK is going to talk next because he has a talk in another hall. Dr. JK Reddy.
Yeah.
Dr. JK Reddy is going to talk on graft fixation procedures, his choice. We all know Dr. JK is an innovator. He is a technical director at Shankara Eye Center, and he has got so many innovations to his credit. Excellent cornea, refractive, and phacosurgeon. It's over to you, Dr. JK.
Thank you, Dr. Suresh, and you are so passionate about this pterygium. I'm seeing you doing this work. IC courses for a long time, more than 15 years. I have guidance. So coming to the graft fixation, to be quick with the presentation, and there are so many methods that Ellen Kumar has shown, right from suturing, autologous, and the other methods too. So what is the best for it? So the best of all the techniques is still the T-cell bags or T-cell. Maybe there is some problem with the availability, but it's freely available. Sometimes there will be a little problem with the stocks. So little tips how to use this is more present. First is you have to do very gentle cautery, not too much, because pterygium surgery you should not produce an inflammation, because if there is a blood clot under the graft, then it may get dislodged. So we have to do very gentle bipolar cautery with a very low power, just to stop the bleeding, not to make the sclera white, just to stop the bleeding. There should be blood vessels and they should be visible. You should not worry about them. You should not bleed. That's all what we need to cauterize. If you don't cauterize, if you don't need to cauterize, if there is no bleeding, but if there is a small amount of bleeding, better to stop it before you put the glue, because subconjunctival subgraft hematoma is a little bit very awkward, and sometimes the graft gets dislodged. Then coming to the application of the glue, we have two components. One is the concentrated protein sealant component. I prefer to take in 2 syringes instead of using their own applicator that's very bulky and very messy, and take it in a small needle, 26 needle, and put very few drops. Don't be very generous here, because too much glue between the graft and the sclera is not good. You need a very thin layer in conjunctiva autograft, not very thick, messy, very thick barrier between the sclera. We want to stick the conjunctiva graft to the sclera. We don't want a barrier. If you put too much glue, it will form a barrier, forms a thick layer. It takes a long time to get vascularization. Then a little bit we can press the attach the graft, the conjunctiva, we can push it, then reflect the graft onto the bare area. We can wait 10 seconds before we shift it. So that much time it will take it to thickening and for both components to get mixed up. Then sweep over the graft and remove the excess glue from tissue glue from under the graft and the sclera. That's what I like it, so that there is a very thin layer, and the excess glue which has come out, just don't pull it off. If you pull, the graft also comes out. So cut with the scissors, lift it and cut with the scissors, whichever has come out while you are sweeping the graft, the glue. Then you take it off and keep it clean. Otherwise, sometimes the patient pulls off. The glue will be hanging like a tissue for 1 or 2 days. So the patients, while cleaning at home, they pull it and the entire graft will come out. So remove the excess glue and don't leave it there. And the other method for beginners, especially when you're starting the started using the glue, you're a bit scared that it will loss or conjunctiva get displaced. You can put 2 sutures of tango vicryl at the limbus. And this vicryl generally I don't like, because it's very highly irritant material on the ocular surface. Patients are not very comfortable. Very initial days, we used to put 2 sutures near the limbus first and put on both the sides, one on this limbus, one on this, so it will fix the graft there. There is a graft in the position, and one more suture in the down near the limbus. And either if you don't have a glue, then you can put 4 sutures or 6 sutures all around to cover the other 2 areas. If you have started using the glue, then you don't need to worry about this. Then reflect the graft. This is for beginning, first few cases, to make yourself confident. Then reflect the graft. Then apply as shown before, just 1 or 2 drops of tissue glue and reflect the graft. And this is to make sure that your initial cases, you are not worried about the graft dislodgement. Then post-operatively, if you remove the excess glue within a week, they look very nice without edema. If you leave a lot of glue, what I found in my cases, we have a little bit congenital edema staying for up to 10 days at the graft site. The other 2 things, as Dr. Ellen Kumar has shown, autologous blood. Now tranexamic acid also people are trying. I have not tried this, but autologous blood also works very well. But you have to keep the graft there for at least for 3 to 4 minutes without movement before you patch that. Thank you very much.
Thank you, Dr. J.K. So what is your preferred method? If the patient is affordable, of course, we all use tissue loop. But if the patient cannot afford, what is your preferred method of graft fixation?
See, most of the times the affordability is not an issue in our institute because we use it in multiple theaters. The retina people use it for buckling, and so once one is reconstituted, we don't use for one patient. We use for 1 or 2 days. So there are so many cases, so it comes very minimal cost because you need only 2 to 3 drops. That's all for one case. So out of 1 ml, you get a lot of cases. You can do many. So it's not an issue at all in our hospital. But when in outside practice, when they have once in a while case, once in a 2 weeks, autologous blood works very well. But only thing is we should not remove the patch for at least for 24 hours. And on the table, we have to leave it for maybe for 3 minutes, I prefer. And these are the ones right now. Maybe in future we may get some alternatives.
Thank you, JK. So I request all the panelists to stay back. I have 2 talks. That is one on double head pterygium. The other one is on practical tips to reduce recurrence. So I'll combine it. There may be an overlap. So my slides are visible, right? Shreyas?
Yes, sir. Clearly visible, sir. Very clear.
Okay, yeah. So my topic is on double head pterygium management and practical tips to reduce recurrence. I'm going to combine it. We all know pterygium is a common problem encountered in our day-to-day practice, and the recurrence of pterygium after its excision is one of the most common and frustrating cause of concern for both the surgeon as well as the patient. And this has led to the development of newer surgical techniques, adjunctive measures, and graft fixation measures. And if you don't follow a proper surgical technique, you may have poor or variable outcome. And as such, we do not have any set protocols as to how to manage different types of pterygium. So what are the cases you should operate? If when you're dealing with the pterygium, it's not all the pterygium you can operate. It's only those patients with the progressive pterygium, and those who are having visual disturbance or cosmetic disturbance, or if the patient is not accepting cosmetically, or a patient having a corneal recurrence, not the conjunctival recurrence, the corneal recurrence with symptoms. These are the cases we should go ahead and operate. So if you see carefully here, there is a grade 3 pterygium, and the astigmatism here is close to 13.5 diopters, and you can see the amount of distortion of the cornea here. And after the pterygium excision, this is after 6 weeks of pterygium excision, the astigmatism has come down to 2.5 diopters. If you see the comparative chart here, this is the preoperative astigmatism 13.5, and the post-operative is around 2.5. There's almost close to 12 diopters of correction, 12 diopters of change, which has happened after pterygium excision. So it has improved visual acuity in this particular patient significantly. So what is the chief goal? What is the main goal of any pterygium surgery? It is prevention of recurrence. Any procedure which we do for pterygium, we should prevent recurrence. There can be recurrence, but it should be minimum. And the procedure should create a limbal barrier so that there is no conjunctivalization of cornea. And there should be minimal or no complications, and it should be cosmetically accepted by the patient as well as the surgeon. And there should be visual improvement in case there is a severe distortion of cornea. It will definitely improve the visual outcome in these patients. So how can you achieve these goals? By removing all the reactive fibrovascular tissue, by eradicating all the mutant pterygium cells, and thus you are going to restore the smooth surface, which is easy to reepithelialize, and we are going to restore the normal limbal barrier. That's how you're going to manage these pterygium cases. So I'm going to show few video clippings. This is a normal, it's a primary pterygium, grade 4 pterygium. I prefer giving subconjunctival infiltrative anesthesia so that I can have full cooperation of the patient during the surgery. Actually, you can avoid complications of retrobulbar or perivulvar anesthesia. And after the pterygium excision, this part is very important, smoothing of the corneal surface where the pterygium is attached. And taking a thin graft is again very important. This can be achieved by injecting either lignocaine or saliva subconjunctivally. Yeah. And taking a very thin graft is very important to take a thin graft without the inclusion of tenons. So if there are hardly any adhesions, you can easily dissect a conjunctival sheet. And once that is done, you can either fix it with glue or you can suture it. Whenever you're suturing the limbal end, you have to anchor it to the sclera for proper fixation. Otherwise, there can be sliding of the graft. And again, amniotic membrane can be tried. If the amniotic membrane is available, you can use amniotic membrane also for primary pterygium. The results are equally good. Is a preserved human amniotic membrane, and you can fix it. It prevents fibrovascular proliferation. It helps in reepithelialization. And there was a study which compared primary pterygium with conjunctival autografting and primary pterygium with amniotic membrane transplantation. As far as the primary pterygium treatment is concerned, both are equally effective. Almost the recurrence rate is almost comparable. But for recurrent pterygium, the recurrence rate with amniotic membrane is very high. So per se, amniotic membrane transplantation for recurrent pterygium is not effective. So when we all know conjunctival autografting is the gold standard in the management of pterygium. However, there are occasions where the superior bulbar conjunctiva is not available, like patients with glaucoma filtering bleb or a glaucoma suspect, or patients who need a large graft, like case of double head pterygium. Such cases, you can take a tissue graft from the conjunctiva pterygium itself. This is a case where I'm taking a graft from the pterygium tissue itself. So you just inject lignocaine subconjunctivally and take a thin sheet of epithelium from the pterygium itself. It's a little difficult to take a graft from the pterygium. It's the epithelial sheet which is slightly thicker as compared to the normal conjunctiva or virgin conjunctiva. And it's brittle. It loses its elasticity when it is on the pterygium. And then you remove all the fibrovascular tissue and place this graft or epithelial sheet or conjunctival tissue from the pterygium itself, either suture it or glue it. So this works very well. You need not discharge the superior bulbar conjunctiva or inferior bulbar conjunctiva. And this particular technique has been published as a concomitant use of conjunctival tissue graft from the pterygium itself. And it was published in IJO 3 years back. And the results, as far as the recurrence rate was concerned, it is comparable to conjunctival autograft. And we even compared this conjunctival tissue graft to inferior bulbar conjunctival autograft in patients having filtering blebs and those who are glaucoma suspects, and the results were comparable. And it is seen that in situations where sparing of the superior conjunctiva is mandatory, both the techniques of inferior bulbar conjunctival autografting and conjunctival tissue graft from the pterygium itself, they are excellent alternative options with the comparable outcomes without any additional risk of significant complications. Coming to recurrent double head pterygium, it's a different management problem, slightly a difficult management problem. Here you can do conjunctival autografting You can use superior and inferior bulbar conjunctival autograft for covering the bare area, or you can do what is called a split conjunctival autografting. It can be a horizontally split conjunctival autografting or vertically split conjunctival autografting. Horizontally, these split conjunctival autografting also, like with the limbus to limbus orientation and without limbus to limbus orientation, can be tried in these cases. And we can even, as I have shown already, conjunctival tissue grafts from the pterygium itself can be taken, and amniotic membrane transplantation also in primary double head pterygium can be tried. And vertical split conjunctival autografting without limbal orientation. Why we tried this technique is, we have split the conjunctival graft vertically into two components, two parts, and we slide the graft to the bare area. So you're not able to cover the entire bare scleral defect. There is a defect which is left uncovered. So this defect, uncovered defect, can act as a bare sclera, and it can cause conjunctivalization of cornea. There is no barrier here. So there will be conjunctival fibrosis which can encroach upon the cornea. So in such cases, what we can do is we can split the graft and slide the graft vertically down without changing the orientation of the graft, and place it on the bare scleral bed and cover the entire bare scleral defect. So this works very well, and this is the video demonstration of the same procedure. I just split the conjunctival graft into two parts vertically, and one graft I place on the nasal side without changing the orientation. There is no limbus to limbus orientation. This is the limbal end of the graft, and the other part. But of course, the epithelial side should always be facing upwards. This works very well, and we even published the results of this technique, double head pterygium excision with modified vertically split conjunctival autografting, 6 years long follow-up, and the results were again, as far as the conjunctival recurrence of the pterygium was concerned, it was excellent. We had less than 4% recurrence in a series which contained almost 100 cases. We even published a large series in Oman Journal of Ophthalmology with this unconventional way of doing vertically split conjunctival autografting, and the recurrence rate was around 2.1%. And then we even compared this vertically split conjunctival autograft with and without limbal orientation. Again, the results were comparable here. This study actually provided data that recurrence rates are not different among patients who undergo split conjunctival autograft with and without limbal orientation. So the strict adherence to maintaining limbus to limbus orientation while managing double-headed pterygium may not be necessary in all cases, especially in those with the large defects following excision. Coming to the other mode of management is the horizontal split conjunctival autografting. You split the graft, you take a large graft superiorly, split it into two parts horizontally, and place it on the bare scleral bed. This also works very well. And again, so on the temporal side, I have not followed any orientation. We again compared this, and this was published in last December, IJO, comparison of horizontal versus vertical split conjunctival autografting in the management of double head pterygium. Again, both the techniques provide good results with comparable efficacy in terms of rate of recurrence and complication profiles. So coming to recurrent pterygium, Shreyas has covered this. What is recurrent pterygium? It's nothing but regrowth of fibrovascular pterygium-like tissue growing onto the limb, beyond limbus and onto the cornea. And this fibrovascular recurrence attaining the same degree of corneal encroachment as the original lesion, or regrowth exceeding 1 millimeter onto the cornea. So it is called recurrent pterygium, and this is a corneal recurrence. It's a proper recurrent pterygium, And there is a recurrence of conjunctival tissue here, but the limbal area is covered. There is a barrier effect here. There is no conjunctivalization of the cornea. This is called conjunctival recurrence, and it doesn't require any treatment. Management, again, surgical aspect, Dr. Hayes has covered. So these are all the management modalities which we can use for managing pterygium, recurrent pterygium. Mitomycin C 0.02 to 0.04% can be tried, and there are various regimens, there are various protocols which is followed by different authors, and 0.02 to 0.04% is apt for the management of pterygium. It can be used intraoperatively or it can be used post-operatively, and there is a study which compared 0.02% with 0.04% of mitomycin C. And as far as the recurrence rate was concerned, both are equally effective. So we can always use lesser concentration, that is 0.02%, if at all, if you have to use. And it was compared, the mitomycin C for recurrent pterygium was compared with the limbal conjunctival autotransplantation, and the recurrent rate was almost comparable, and both are equally effective. Intraoperative versus post-operative, the recurrence rate, there is no significant difference. Various studies have proved this. However, one should be careful in handling mitomycin C. If you are using mitomycin C, you should be in a position to handle these dreaded complications. This is a site-threatening complication. We all know pterygium is not a site-threatening condition, but a site-threatening complication like this is not acceptable in the management of pterygium. My preferred technique for recurrent pterygium is an extended resection of the pterygium. It's not as extensive as described by Hurst, Professor Hurst, in his perfect technique. It is an extended resection, and I use a large graft where I use a thin block of tissue from the peripheral cornea that includes limbal stem cells. So this is a procedure which combines extended resection with the limbal conjunctival autograft. This works very well for recurrent pterygium patients. So we have different treatment options for different types of pterygium. Single head and double head primary pterygium, you have these many options, and for recurrent pterygium, you have all these options: conjunctival autografting, limbal conjunctival autografting with adjunctives like mitomycin C or amniotic membrane transplantation. So what are the causes of recurrence after conjunctival autotransplantation? If you see here, the insufficient graft size. There's a small graft here, there is a bare area left. So in this area, definitely there can be conjunctivalization. There will be proliferation, fibrovascular proliferation of the conjunctiva here. And thick graft, if you are including tenons in the graft, this is a graft, conjunctival graft with the thick tenons, and over a period of time, this sloughs out, and it can cause loss of graft because of the retraction or contraction, and it can cause recurrence. And retraction of the graft, if you are taking a very small graft, if it is not adhered properly, you can have a retraction like this. Luckily, the limbal end of the graft is well opposed here, so the chances of recurrence is less, provided unless the patient has recurrent inflammation. If the patient has recurrent inflammation, you may end up having recurrence. This is again a case of graft sloughing out of the graft slough. This is because of the inversion of the graft. If you are placing the graft upside down, you end up having a sloughed out graft. So this has to be removed, otherwise it will cause a lot of inflammatory response, and it can cause conjunctivalization of the cornea. Again, inadequate peripheral excision, as was mentioned in the previous talk. So you can see a small knuckle of tissue which is extending onto the cornea, and the other area, it is all covered with the conjunctival graft. So there is a nice barrier effect, but here the peripheral conjunctival tissue which is extending onto the cornea, that suggests there is an inadequate excision of the pterygium has happened in the periphery. And persistent inflammation again is one of the cause for recurrence. So what are the essential factors to successful conjunctival autografting? These are all the factors we have to keep it in mind. So we have to remove this fibrovascular tissue adequately, and you should obtain a slightly larger graft and obtain a thin and free graft. As a thin graft has to be taken, and adequate stabilization of the graft is very important. There's no point in just taking the graft. If it is not adhered properly, you may lose the graft and it can lead to recurrence of the pterygium. And stabilization of the graft has been shown. This is actually autologous.
With all due respect, Dr. Sresha, actually it's time up. Could you just please sum it up in the next 30 seconds?
Yeah. Okay. So I think
Thank
we
you
have
so much.
2 more minutes. And yeah, this is actually a conjunctival graft which is placed on the autologous blood. The blood is already clotted, so it may not stay. It may not stay. So you need fresh ooze, like for the graft to fix. So in such cases, you may not have a stable graft. You can just scratch the bare sclera here, and there can be fresh ooze like this, which will cause clotting of the blood once you place the graft on the vascular bed. And see to it that the graft is stable, and put an overnight patch. So 6 hours of patching is sufficient. And this is the last slide. And I'm showing just a conjunctival autografting and fixing. If you don't have a glue, you just place the graft on the vascular bed. There can be some amount of ooze, which is autologous blood, autologous serum. And then you cauterize the edge of the graft using your cautery. So I'm just cauterizing the edge. This actually fixes the graft. I've been doing it for a few of my cases, and the results are good. Again, the results are comparable to autologous blood or even glue. So to conclude, you have to choose the right surgical procedure, and you have to choose the right method of graft fixation to obtain optimal outcome in these cases. Finally, it is a surgeon's choice or surgeon's expertise that will guide this technique of surgical procedure for pterygium or a graft fixation procedure. Thank you very much. Do we have time?
Thank you so much. No, sir, we actually, it's a timeout. I mean, the session was going to be end at 10:55 p.m.
Okay.
Yeah.
Thank you.
Thank you so much, Dr. Sresha Kumar, for being such a wonderful chairperson, and all the lovely speakers who had such an informative session.
Thank you.
Thank you so much.
Thank you so much, SK sir, for the wonderful session and real masterclass. Last talk was wonderful, sir. Thank you so much.
Thank you, Shreyas. Thank you.
Thank you so much for being a part of the AIOC. Have a nice day ahead.
Okay.